Quite frankly, airway management doesn't end once the breathing tube is placed into a patient's airway. It is also making sure that that airway doesn't cause secondary infections or complications down the road. The ICU has learned through years of pain and suffering that that piece of basically maintaining the airway in a way that it doesn't cause secondary complications is paramount.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now it's time to roll back and start the first case.
This week on First Case, we speak with Dr. Benjamin Wang, an anesthesiologist in California and the CMO and founder of NeVap. And we're going to be talking about subglottic or airway drainage during surgery, which some of you may know and some of you may not know can cause additional damages to the lungs during procedures, Melanie.
Yep. Sign me up for somebody who did not know. This is a completely new topic to me. When Dr. Wang reached out to me and said that this would be a good topic for education, I'm like, tell me more, because this is not something I've heard of before. And so I really think that our audience is going to gain a greater understanding of not only the structure and anatomy of the airway and what we're dealing with our patients, but also what they can be exposed to if we're not fully aware of all of the risks our patients are having when they're intubated.
All right, stay tuned. This is an interesting one. We're going to be right back after a short break with Dr. Benjamin Wang.
I'm Melanie Perry.
And I'm Justin Poulin.
A 17 Studios production, you're listening to First Case.
Joining us now is Dr. Benjamin Wang, an anesthesiologist in California and the founder and CMO of NeVap. And Dr. Wang, we're going to be talking today about subglottic or airway drainage. We're going to be talking about that during surgery and also ways to reduce hospital-acquired infections, which is top of mind for hospitals today because that costs us so much money. And with the pandemic especially, but also the Affordable Care Act, the finances have never been tighter in healthcare. And the number one revenue generator, as most of our audience knows, is the operating room. So why not target efficiencies there? Thank you so much for coming on the show today.
Well, thank you so much, Justin, for having me. You know, as we know, we're still kind of in the middle of a pandemic, although many of us like to believe we're not. And one of the things that we've learned, and most of the world has learned, is there's actually a lot of hospital-acquired pneumonia occurring in many of these pandemic patients.
That is really interesting. What a phenomenal table setter as we, jump into this, because it seems like what you're telling us is it's an increasing issue. Before we dive into that, can you talk about your background? And I'm interested in your experience before kind of moving into this entrepreneurial realm that you're in. And, that's something that I'm obviously very interested in because I'm an entrepreneur myself, but I'd like to hear how you transitioned or, continue to work as an anesthesiologist and then started a company. Maybe talk a little bit about your background.
Absolutely. I trained at the University of Miami. And anybody who's ever visited Miami will realize it's a very, very diverse place in the United States where we have people from all over the world coming in and, all kinds of people coming into Miami and doing all kinds of interesting, unique things. And unfortunately, sometimes that stuff ends up in the hospital. And anybody who works in Miami will tell you, many of the hospitals are some of the most busy and diverse places to practice, and that includes the ICU. But what is very interesting is while I was there, I was noticing that people we put on long-term mechanical ventilation were getting hospital-acquired pneumonias, and very, very strange, unique pneumonias where the bacteria and the processes involved were unique to the ICU.
Dr. Wang, that's really interesting. And I think it's an interesting observation to notice what you saw in ICU patients. But when you and I talked prior to the interview, you also mentioned that you were starting to notice this in operating room patients as well. Is that right?
That's correct. That's absolutely correct. Many of these long operations involve patients who are already immunocompromised or are undergoing serious surgical procedures for an extended period of time. And when you look at the post-operative pneumonia that these patients will acquire, many of these pneumonias look like the infections that we see in the ICU. And that, for me, that was a light bulb that went off in my head.
Wow, that's weird. So break it down for me a little more. What were you seeing in the pneumonia that you were also seeing in the infections? What bugs were you seeing?
Yeah. So just for reference, community-acquired pneumonia is very different than long-term mechanical ventilated patients. The pneumonia that long-term mechanical ventilated patients acquire. The long-term patients will often acquire things that are rare and that you've never heard about, but oftentimes are very common in the hospital, such as things like Pseudomonas, Actinobacter, fungal infections like Aspergillus, MRSA pneumonias. These are things that we don't see normal, healthy people acquire in the community and then come in to the hospital with. These are the patients that after a couple of days in the hospital, they acquire these rare things, and these rare things are often already antibiotic resistant.
I want to ask you about the MRSA pneumonia, because I don't know that I personally have really heard about that. But when I went to nursing school, I graduated in 99, and MRSA was really just kind of getting its time in the light, right? That was when it was really hitting. And I took care of several patients with MRSA. And then all of a sudden, within about 10 years, you're hearing about people getting it in locker rooms, at sporting events and all of that. But this is the first time I've really heard about it as it relates to pneumonia. Can you talk about that a little bit more as well?
Yeah, you're absolutely right, Justin. In the community, when you hear about MRSA and people coming to the hospital with MRSA, it's usually on their skin or a wound or something, like a cut in their hands or something. And you don't hear it getting into the lungs. And that's by design, because when you're normally walking around, your body has all these normal defenses to keep, bacteria from getting into your lungs. Once we in healthcare start to do something to patients that upsets that natural balance, then you start to see rarer things like MRSA pneumonia. And MRSA pneumonia is unfortunately much more common than it was 10 years ago.
It really is. It's gotten much more common and much more prevalent. And even in my time in the operating room, we would have MRSA positive patients that we're trying to take care of. On top of whatever issue they were having, they've also got an MRSA infection. But I want to walk it back because you mentioned healthy adults and what they, normally have in place to protect them. So let's talk about the normal airway physiology. These patients that we have in the operating room, we're putting them to sleep. If they have a normal airway, what does that physiology look like?
So a normal airway of a person walking around basically looks like a big C. You have your mouth in front and everything that should be going into the right path goes around that curve of the C and then goes down the esophagus. When you're awake, you could do a couple really important things. Number one, you can cough. So if something gets into the wrong pipe, into the trachea, you can cough it up. And that's really our normal response to it. If you've ever sat down in a restaurant and heard a funny joke and things went down the wrong pipe, that cough can be robust and dramatic oftentimes. And it sometimes comes out your nose, which is hilarious.
It's everybody else.
But the problem is when you're in the hospital and we modify the circumstances. First of all, we give people medication that basically takes away that cough reflex. Then now suddenly things that would normally be coughed up will go down the wrong pipe. And when that happens, it bypasses some of the defenses we have. A number two thing that we do is we give anesthetic. And that anesthetic will actually paralyze these small cilia or finger-like cells inside the airway that normally would sweep things up and out so that you can cough them up, just in case something fell down the wrong side. And the last thing we do is, oftentimes when we put something that doesn't feel very good into the airway, we'll use a paralytic agent. And once we use that paralytic agent, all the muscles inside the neck that would normally be trying to push things into the right place and keep the airway a certain shape kind of become all floppy. And that also adds to the problem. So imagine something that by design wanted to stay up and stay strong and get everything out. And then all of a sudden we knock it out with the medications because they're necessary. And then we put something down that basically acts as a super highway for those things that we want to keep out to be there.
It's a really good comparison, a really good way to think about it. When you talk about the paralytics, and you were talking about it just making everything kind of soft and paralyzed, how long after a patient has been anesthetized, and even when we wake them up and send them to PACU, how long is that paralytic really affecting their airway?
Well, it's going to depend on each different patient because some patients are going to respond differently to the paralytic. Depending on how the medication sits and is metabolized in the body, that time could be 10 minutes. But the entire time that they're on the operating table, that paralytic agent and those medications are in full flux, and there is no protected airway. Now, what is interesting is the whole medical device industry surrounding this field has basically said, don't worry about it during surgery. We put a little flimsy balloon, and that balloon will protect the airway. And if you carefully review the literature on this specific topic, there is almost no literature to support the fact that in any kind of thin-walled cuff balloon has any clinical benefits in terms of protecting the airway from fluids that would otherwise go down that path. And what's interesting is as of May 2022, the CDC, in their review of preventing hospital-acquired pneumonia, has basically said they do not support the use of different shaped balloons or thin-walled balloons, and that there is inadequate data to support any kind of clinical claim that these are beneficial.
So if that's the case, right, let's say that we understand that there's no clinical data, but let's assume that the lack of clinical data also means lack of effectiveness, right? I realize we don't have necessarily a direct correlation, but we don't have anything supporting it either. So let's just assume one side of the equation, which is the benefit is minimal. Would that mean the functionality of the balloon is essentially to make sure that no heart obstruction falls into the lungs?
Quite frankly, yes. A balloon on a breathing tube is simply there to prevent excess gas leak. It's there so that you can push air in. There is no other clinically proven benefit of having that balloon there, except that it anchors the tube so people can't pull it out as easily. The entire medical industry has kind of seized on this balloon idea as a stopper for fluid, and they've created really a culture of false claims surrounding what the balloon can do. But simply put, there is no good data to support that conclusion.
So the original functioning of the device was never to prevent fluid. It's just like an assumed additional benefit.
Yes. Yes.
Interesting.
So then when we think maybe comprehensively about airway management, and obviously, we're talking about the balloons around our ET tubes that aren't really doing a whole heck of a lot, even though people think they might be. What should we be looking at instead, or thinking about, to really think about airway management in the best, to keep our patient's best interest at heart, I guess?
Quite frankly, airway management doesn't end once the breathing tube is placed into a patient's airway. It is also making sure that that airway doesn't cause secondary infections or complications down the road. The ICU has learned through years of pain and suffering that that piece of basically maintaining the airway in a way that it doesn't cause secondary complications is paramount. Whereas in the operating room, we're so used to shorter procedures and then, they're sent to a different department that we assume airway management is simply, I got the airway and that's it. The operating room and the operating setting can really take a note from the ICU in that we want to see if there are ways and strategies to reduce complications, even in the operating room, because we know once that patient leaves the operating room and the problems appear, that those problems are still the problems of both the patient, the clinician, and the hospital. Reducing those complications is really the next step.
So what I'm hearing you really talk about is what we kind of introduced at the beginning of this conversation was this term subglottic drainage and potentially it being the culprit in some of these pneumonias. But I don't necessarily maybe have a full understanding, and maybe our audience doesn't either, as to what subglottic drainage is. So can you explain that and tell us what's going on?
Absolutely. So the subglottic region is a region inside the airway trachea that is right below the vocal cords, in a place where we normally can't see. Fluid and bacteria and pathogens will oftentimes pool in that area, right below the cords. Vocal cords, and as a consequence, over time, those fluids and bacteria will actually enter into the lungs and cause the complications.
So, Dr. Wang, I'm assuming then that the subglottic region is really that area right below the epiglottis.
Yes, and that's an important fact to remember because that's a region where you cannot do deep suctioning or suctioning in the mouth to get to.
So you're completely limited with what you can do with your patients if you don't have anything stopping that fluid or that bacteria from running into the lungs if you can't suction it. Is that right?
That's absolutely correct. And in certain procedures, especially some that we're operating on the stomach or the thoracic cavity where there's manipulation of intra-abdominal pressure, that could be an instant risk factor for having fluid come up and enter into the subglottic space.
So that creates like potential for pneumonia. Is that the only complication, or are there other complications as a result for allowing fluid to enter into the lungs throughout the procedure?
There absolutely are other complications. If you get stomach acid or even bile, caustic agents that come from the body, or even other foreign substances that maybe the patient could have ingested, those substances can cause severe pneumonitis. And the volume that you need to actually cause those problems is very well documented in the literature. And it doesn't take very much. In fact, we know that about 10 cc's of bile will just about kill a patient.
Wow. It's incredible to think such a small amount could do so much damage. And speaking of effects to our patients too, besides maybe hospital-acquired pneumonias, what are the long-term effects to our patients when they're dealing with these infections or this exposure from subglottic drainage?
Well, even if a patient doesn't clinically reach that benchmark of having a pneumonia or a hospital-acquired pneumonia, many times they'll leave with permanent lung damage due to like a pneumonitis or other kind of inflammatory processes in their lungs. Depending on the patient, you may have issues with them being readmitted down the line, or even within a couple months of their initial hospitalization. Specifically with these COVID patients, part of the long COVID syndrome that we see is a lot of scarring and damage to the lungs, where they will come back for the next year, several years.
That really begs a question I have to ask you, because I've seen this in other areas of surgery like minimally invasive, where you can't really visualize a laparoscopic instrument except at the very tip, where you actually are seeing it with the camera. So if there is electrical leakage, we don't always know that damage has happened unless there's a post-operative complication. I'm wondering if it's the same thing in this arena that you're describing, that, the only way we would know if there was any subglottic drainage that had gotten into the lungs, the only way we would know that is if there was some sort of a complication after the fact. Is that true? That's the only way we would know?
Yes, 100%.
All right, so that's concerning, and I'm going to ask you because I know you're going to add to that, but I'm going to ask the next logical question that goes piggyback with that, and I think you'll tie it up into a great answer. So I guess what my question is if we only know when there's a complication, might there also be minor damage or even latency for the effects of that damage that we're just not able to track or don't have an awareness of? Is that at least a possibility?
Absolutely. Absolutely. And the key to this is, are there strategies that we can adopt from the ICU in the operating setting or even preoperative setting that can lead to better outcomes for patients and less, complications for hospitals and clinicians down the line? And what is very interesting is the University of Washington in St. Louis is actually doing very innovative research in transplant patients on this exact subject.
All right, so I'm listening to you talk about the long-term effects from patients when they're dealing with infections and pneumonia from the subglottic drainage and the problems they're exposed to. And then my brain, of course, jumps to COVID because we've been living with COVID for, it feels like 100 years at this point, even though it's only been 2 or 3. But is there a connection because they were intubated for so long that drainage they were exposed to maybe just created even more damage than the COVID did all by itself?
Quite frankly, I believe so. And I would, in order to maintain my credibility, I will just try to dance around this a little bit. Here in this country, we don't track this type of pneumonia and this infection very well. We simply have a policy of not tracking ventilator-associated pneumonia because it's a hospital-acquired pneumonia that makes the hospital look, unfortunately, bad. And there are penalties attached to respiratory and long-term care complications such as ventilator-associated pneumonia. So a number of years ago, we transitioned from calling these pneumonias to calling them ventilator-associated events. And that actually makes very little sense because what we did is we grouped pneumonia with ARDS, with changes in ventilator settings, with pneumonitis and, restrictive lung disease. And we basically decided we were going to cover it up. It's kind of like taking brain tumors and lumping them into a group with melanomas and saying they're all cancers.
Yeah, right.
When you do something like that, you actually can't start to try drugs or therapies that address melanoma or brain cancer because maybe something works for brain cancer, but kills the patient because it doesn't work with melanoma. And so we've moved in that fashion where we are just trying to cover them up. And as a consequence, the rest of the world, when they looked at COVID and when they were publishing on COVID, they tracked an enormous amount of ventilator-associated pneumonia. Here in the United States, we tracked ventilator-associated events. And even though we saw, a double-digit increase during the surges, what happened was nobody was connecting this with pneumonia. And as a consequence, nobody was connecting it with, hey, let's try strategies to prevent these pneumonias to lead to better outcomes, which would have been the logical way of actually thinking about COVID. Now, what we know is the American Society of Chest Physicians actually published an article with data coming from Italy that showed the rates of pneumonia in COVID patients were somewhere between 40 and 45% of intubated COVID patients. Keeping in mind that 30% of the sepsis that we normally see in ICU is actually because of COVID and because of ventilator-associated pneumonia, you start to grasp what the scale of the harm that this had for these COVID patients. Now, if you get a really nasty viral infection, a pneumonia like the flu, and then you get a nasty bacterial infection on top of that, in medicine, we call that a super infection, where the mortality rate goes up tremendously and the morbidity also increases dramatically depending on the patient population. That almost certainly happened in these COVID patients because the virus itself was the inciting incidence, which created basically a situation where the bacteria and the fungus could also go in there and do additional scarring and damaging to the lungs. Yeah.
It's very interesting. It's something to chew on and think about and wonder about the connection for sure. I have one more question before we wrap. Time has flown by quickly and I have learned a lot sitting here talking to you, but I'm curious, how do we prevent these infections and how do we improve patient safety moving forward?
Well, we really look at the data and we try to be honest with ourselves in terms of what we're doing and what we're not doing. Back in 2021, an article was published in South Korea where these researchers were using subglottic drainage in the anesthesia recovery setting. And they found that if you used subglottic drainage devices in the anesthesia recovery setting, that you would reduce the risk of pneumonia 600%. And that's really, really telling because that's saying that we actually have many of these tools available to us. It's simply the practice and the way we silo these problems. Because if you're in the operating room and your airway management regimen is, I put the tube in, hook it up to the ventilator, and I'm done, that's a disservice to the patient. That's a disservice to your fellow clinicians down the line, and maybe even a disservice to the hospital, simply because the risk of something bad happening doesn't end once the tube is in place. And we have to start thinking more about how we can take steps to ensure that there are fewer complications even when the patient leaves the operating room.
Dr. Wang, this has been an absolutely phenomenal interview. I like how you took lessons learned from the ICU and brought it over to the operating room. And I think being more considerate, of this situation, especially as you very aptly kind of wrapped us up there, do it for the patient. There's all these other reasons, right? Do it for the hospital, even the business sense, like hospital acquired infections and readmissions are absolutely burning healthcare dollars. And so if there's anything that we can do to help prevent that, we need to put a lot of focus on it, but also just for the patients. And as you also mentioned, the incidents of people being on respirators, I remember getting calls from old customers of mine saying, can you help me find equipment? There's not enough equipment out there. So that alone tells you just how many more people were on these machines for extended periods of time, how we weren't prepared for it. And, it would be great to think that the data ultimately, even if retrospectively on a correlation study, could tell us a little bit more just because of the amount of volume of use would be really interesting as well. So do you have any final thoughts before we wrap? Because this was excellent food for thought and you did a phenomenal job on the show today.
No, I think your audience would be better served really to think about it themselves and to look at their own situation and find cases where it makes sense in their own practices.
That was Dr. Benjamin Wang, an anesthesiologist in California and the CMO and founder of NeVap. And Melanie, so many interesting points of discussion from today. And honestly, I'd never even heard of MRSA pneumonia. I guess it sort of makes sense, right? If you have to treat it with antibiotics, that eventually there would be multi-resistant bacteria, of some type, maybe not MRSA, but any of the other types. At some point, they're going to develop that resistance to antibiotics, but I just never had heard of it. And this whole idea of, pneumonia that's caused by intubation and especially during COVID on ventilators, it's kind of blowing my mind a little bit.
Yeah, my mind's a little blown too. He made me really rethink our process in the operating room when, kind of like he said, it's like you put the tube in, they go to sleep. I'm not saying anesthesia's work is done by any means. I know that that's not, but thinking about that airway after the tube comes out and away they go again. And actually there's a connection even from the OR when they were intubated off to recovery and maybe even to ICU, and everything is interconnected because of that drainage they potentially were exposed to. And it's kind of mind blowing to think about the interconnectedness of it all.
Yeah. I had no idea that there was drainage that could possibly be leaking into the lungs during that period of time.
Yeah, me
That's
either.
crazy.
Yeah.
All right, well, that's going to do it for this show, a good one in the books. And as a reminder, you can help support First Case by subscribing on Apple, Amazon, Google Podcast, Stitcher, iHeartRadio, Spotify, or simply search for First Case on your favorite podcast application. We do have bonus content for some of our episodes, but you can't find it unless you download our smartphone app for iPhone and Android and then click on the gift box associated with the episode. We'd certainly appreciate a rating and a review if you're there downloading the app, because your feedback is important to the show. And speaking of feedback, if you'd like to send any in to us, maybe a future guest or future topic that you'd like us to cover on the show, just send an email to info@firstcasemedia.com. On behalf of Melanie and myself, thank you for listening to this week's episode of First Case.